It is a wonderful honor to welcome Dr. Sally Satel on this podcast. She is the lecturer at the Yale University School of Medicine, as well as a senior fellow at the American Enterprise Institute. Um, I would like to discuss her recent article in the Free Press. It is titled Mass General Brigham Puts Anti-Racism Against of Their Patients' Health. And from that, we can move on to the larger topic of anti-racism in medicine. Sally, welcome to the show. How are you?
Oh, good. Thank you so much.
I'd like to ask you first, how did you come to know my show? I understand that so far my program is somewhat under the radar.
Oh, I think you invited me on maybe 2 years ago. I
Oh, right,
finally,
yes.
yeah, that's
Huh,
how I know about you. But now I get the notices every day, and I see what such an impressive array of people you have.
wonderful, thank you.
Yeah,
Yeah,
been a
I
good
couldn't remember.
conversation.
I couldn't remember what was the proposed topic of that conversation,
Oh,
but
I
I
should have
figured
looked it up before we started. I,
yeah,
I mean, I can look it up,
yeah.
but yeah.
Oh, right. I think it was has something to do with an article that you wrote in the Liberties Journal. Um, yeah. So the one that you wrote about addiction. So yeah, that was
Okay,
also a wonderful article, and I think I can link that in the show notes as well.
thank you.
Yeah. I think if you can remember that article, how would you summarize it to our listeners and readers?
The addiction article?
Yeah, yeah.
Oh, okay. Well, basically, it was a sustained argument for why we shouldn't hyper medicalize addiction. It has enormous psychological components and behavioral components, and also cultural components. And the dominant narrative now about addiction, actually, it was first introduced in 1995, so it's almost a 30-year-old framework for thinking about addiction proposed by the National Institute on Drug Abuse, is that addiction is a chronic and relapsing brain disease. And I can't tell you that that's wrong, although actually the relapse rates are I think less than that implies. But it's not so much wrong because it's really almost a philosophical question about how do you define addiction? What's the essence of it? But I think the most productive way of thinking about addiction is is as a behavior that responds to contingencies, so to carrots and sticks, and that people engage in for a reason. They're not just overtaken by the substance. So it was a long, like, gosh, like 7,000 words on that. And it was grounded in a year I spent in a small town in Ohio. Uh, because I'm a psychiatrist, I could help out a bit with the addiction treatment efforts, and I also explored, a difference between what I'd call addiction at the level of the individual and addiction at the level of the community. And it's in that latter domain that epidemics. That's what an epidemic is, geographically isolated. Epidemic of, fill in the blank, in New York City in the late 80s, early 90s, it was crack, same with LA. In the place I was, called Ironton, Ohio, it was largely opioids, but, over the last few years, it's morphed into a lot of methamphetamine too. And now fentanyl, of course, is really a killer. It's um, many times, like 100 times more potent than morphine. So it's very deadly.
Mhm. Yes.
Yeah. So that was the main point: is not to not to apply a reductive lens to addiction, because if you do, it's not going to help. I would say the two major sets of stakeholders, I hate that word, but which is to say people who treat addiction and people who make policy, they need to think about addiction at a kind of really also more human level, and not just the level of the brain. If you're a neuroscientist, that's great. I work in a methadone clinic, I should add, so in no way am I opposed to medical interventions for addiction. They certainly have a role, a huge role. I think methadone is enormously helpful, but they are the virtue of those interventions is that they help people stand still, which is to say, it helps them control intense cravings, and it subdues the withdrawal symptoms so that they can begin to focus on recovery, which is a very long process usually.
I see. Yeah, I was just out for a second. I think the oven in my house, it was finishing cooking something. So, yeah. So to what extent is addiction, either of opioids or of other substances, being discussed in, I guess, the American public policy circle, and more specifically, the ongoing presidential election this year?
Yeah, it's funny you ask that because a lot of people are saying, why isn't there more discussion? There's more deaths from drug overdoses, and as I said before, almost mainly from fentanyl, than ever before. I think over 100,000 people died from any kind of drug overdose, and at least 3/4 of that involved fentanyl. So, yeah, people are saying, I hear a lot of lamenting that it's not really on the front burner. I mean, it was in the 2016, I wouldn't say front burner, but it certainly got attention in 2016. I think there's no question about that. And a lot was made of the fact that the states in which the overdose rates were highest were the ones that had voted predominantly for Trump. And in fact, that's when J.D. Vance's book, Hillbilly Elegy, was really like a perfect storm, temporal storm, because a lot of people had turned to him and that book, and I think it was an excellent book, as a kind of interpreter of the white rural experience, and the deaths of the quote unquote deaths of despair in the context of their lives, the economic devastation, and then which usually leads ultimately to some social unraveling. And also right around that time, I guess I'm combining a lot of factors at once, was the phrase deaths of despair, which was coined in 2015 by Angus Keaton and Ann Case, who were economists at Princeton, in which they had noted, this was in 2015, the profile has changed a little bit, but it was almost exclusively premature white deaths from overdose, liver disease, which basically means alcoholism, and suicide. And if those three, it was drug overdoses that accounted for most of those deaths. So yes, it was, I think, very much in the spotlight 8 years ago, and now it's faded. I'm not sure. I think there may be a sense that I think there's less of a pressure on trying to understand it. I think people feel, and not incorrectly, that we sort of know what to do from a clinical standpoint. It's just that the infrastructure is too weak. I mean, we know that, as I said, methadone is very effective. There's a drug called buprenorphine or Suboxone, same thing, which is a drug that, like methadone, is basically an opioid replacement. But it's not available in enough places, don't have enough residential treatment. That's an old story. And then, of course, Narcan or naloxone is the antidote. And, I think a lot of the towns that are getting money from the opioid settlement are just buying a lot of Narcan because, the overdose rate did drop. The new numbers just came out like the other day, and there was a small decline. And I'm not sure what that reflects. Maybe it reflects more Narcan use. And in our methadone clinic, we hand it out every day. We're pushing it into people's pockets. Take the Narcan, take the Narcan. It's not for the person, the patient, but it's for the person that patient is with when they're using drugs together. because obviously if you're overdosing, you can't administer a nasal antidote to yourself. But and we have patients who say, frankly, who kind of treat it as if it's a matter of fact thing. Yeah, oh yeah, I used Narcan. Yeah, I used Narcan on my husband the other day. Oh yeah, it's like nothing. It's becoming very normalized. I think that's it's a sad statement, but it's still a good thing that that medication exists. So that's really more of that's where the emphasis really is. Let me just finish by saying I do think there's a fair amount of emphasis on fentanyl and at the border and fentanyl interdiction. That's very important. I do hear a fair amount about that. Um, and you're starting to hear more about the perhaps lack of success of decriminalization, with a spotlight on Oregon, which just reversed or is about to reverse its decriminalization effort that it passed. I want to say 2 years ago. It may have been 3 years ago, but it's been a disaster for lots of reasons that people debate, which is the most, which reason is the most powerful, and should it really have led to a retrenchment of policy, meaning that people will now be arrested for possession. I mean, you can debate that, but that's been in the news. So that's the way it manifests most, I think, today.
Okay. Well, I think we should move to the main topic of the hour. So, anti-racism in medicine. So again, like as I've mentioned at the beginning of the show, you put out a very poignant story about Mass General Brigham. So, why don't you summarize what they do and why do you find that objectionable?
Sure. Well, I think it was late March, possibly early April. Mass General or it's now Mass General Brigham is its formal name, had made an announcement that Black women are more likely to be drug tested. These are Black women who are expecting babies. They're more likely to get drug tested and then more likely to have their children taken by Child Protective Services if they test positive for drugs than are white women. And that in and of itself, on its face, was a problem. Now, there are a lot of basic issues. The first one is this is kind of a hard problem. Is what do you do with expectant mothers or someone who's delivered a baby and they're using drugs? We're certainly much more harsh in the past, where women have even been arrested for that was the crime, or endangering a child or something. And in some states, there's a state by state differences in how this situation is handled. And in some states, they're still pretty punitive in that way, although I think most are not. But in Massachusetts, in the Mass General, they were distraught not by the idea that women may be pregnant and using drugs, which doesn't always hurt the baby, does not always hurt. That's something to keep in mind. And also having babies, when they were also in the midst of an addiction. So this is tough things to deal with. And the main reason is because you don't want women to think that if you are going to drug test them, you're going to use it for purposes that will get them in trouble. Like that means if they're positive for a drug, immediately you're going to call Child Protective Services or even the law enforcement. And so they will stay away, and then they won't come in for prenatal care. Not that the records necessarily of prenatal attendance are so great, but you don't want to deter people at all. So it's a real tension between those two things, being attentive to any danger the mother or the baby could be in from the drug use, but again, not scaring them off. So, and that's a real issue. And from what I can tell, hospitals are trying to be very sensitive to that and offering the women all kinds of options. Please, if you're having, like if they see track marks, or because you do have to ask for permission in most places to take a drug sample, a urine sample, unless it's an emergency situation. But they really bend over backwards to be, please come into our program, or reassure them that we're not going to call Child Protective Services unless we're afraid of the health of the baby, anything like that. And I think that works in a lot of cases. But the point is, if you are concerned, if doctors and nurses have reason to be concerned, and the mom is really not being too attentive to her health, or her prenatal health, then sometimes there has to be some intervention. That's a last resort, but it does have to happen. And the real question then issue is, are we treating these women who may be at risk as sensitively as possible, not whether, unless there's gross evidence of discrimination, which simply testing one group more than another is by no means evidence on its face of discrimination. Drug testing shouldn't be equally applied across groups. It should be driven by the circumstances of each individual patient. So what Mass General did is basically say we are raising the bar for drug testing, because we see this differential, which is unacceptable. And that's a huge theme in the I guess you could call it sort of the anti-racism campaign within medicine, is, if we see a difference, unfortunately, now in many cases, it's being just interpreted prima facie of racism. And so if we see that difference, if we can minimize it in any way, we should. And this way of minimizing it, which is to say getting less information, is really unhealthy. So that was the point of the article.
Okay. So just to connect the two topics that we've discussed so far, addiction and anti-racism in medicine. I remember there was stand-up comedy special that Dave Chappelle does. That was around the same time of the opioid crisis, and he was talking about how the opioid crisis finally get people to pay attention to the tragic reality of drug addiction, because mainly the addicts were white. So he was talking about how back in the 80s and 90s, when Black people were hooked on crack, nobody paid attention to them because they were Black people. So to that extent, Chappelle sadly buys into that anti-racism line that you were referring to.
Oh, I agree with that. He's completely completely correct that we responded to the crack epidemic with in extremely punitive ways.
Mhm.
And that when it was a problem of mostly white people, there was much more compassion. I remember so many local police chiefs saying, and became a real cliche already, we can't arrest our way out of this, if you recall that phrase. I mean, it definitely looked different. And I do think race played a role, but there were other considerations. So, for example, a lot of just think about the police, in the law enforcement in those regions. In small towns, everyone knows everyone else. So you probably, if you're a cop and you're called to a scene, chances are the teenager or the young adult. You worked with his father, or you went to school with his mother, and that changes someone's attitude. So because of those connections, I think that breeds a lot more sympathy. And chances are, heaven forbid, your own cousin, has some problems. Also, it's 30 years later. Well, to be fair, now it's 30 years later. So it was 2 decades, 15 years to 2 decades after the crack epidemic, when the opioid crisis started. I guess you could say started the early 2000s. Some people in certain areas might, like Appalachia and northern New England, might peg it to late 1990s. But in any case, but we're still many years away from the crack epidemic. And in the ensuing years, there's been such, I think, fatigue about over incarceration, just cultural fatigue over it. People are turned off by that, and rightly so, for various kinds of crimes. And I think they're also just completely weary of the drug war. And I think those two things also kind of have a lot to do with it, is that the timing of this, in addition probably to the racial, to the complexion of this problem, had significant impact on our response to it.
Okay. Now the way I see it, I've heard two theories as to the origins of anti-racism as an umbrella of idea. So one would say that anti-racism comes from, say, critical race theory, which again comes from the academia. So this is something that a few either black or white professors have thought of, and it has reached containment and now reached the mainstream. But the second theory, which I've heard someone like Harvard's this Randall Kennedy propose,
Uh-huh.
I think he's someone who is generally against anti-racism,
Mhm.
but he knows that it comes from this idea that statistically you see a lot of racial disparities, mainly between blacks and whites, in regards to say incarceration or arrest by police, and in your case, women being tested for drugs. And people like Kennedy believes that anti-racism is a false solution to a real problem, and that problem is disparities between the races. So I wonder where do you fall in this particular conversation?
Oh, I would agree. I mean, there's no question these differentials, discrepancies, disparities exist in health as well, in terms of health status, in terms of access to health. Yeah, that's not the issue. It's the solutions that people are gravitating to that worry me. And here's one example, which is really a very broad one, but there is now the field of disparities has become a research field. Just finding differentials has almost become a job for some researchers, and that's fine. These I generate hypotheses and they point in directions of something being wrong, but when you're a doctor, you don't care about disparities. You care about the person in front of you. Disparities is a public health concern, and it is legitimate, but it does not have anything to do with doctors. When I see a white person come in, I do my best for him. When I see a black woman come in, I do my best for her. There was a time where there was a fair amount of discussion about doctors being racist. Luckily, that subsided. Of course, an individual might be, but as a group, I don't think that's a problem. But the only disparity that doctors care about at the level of the individual, which is my patient as healthy as he or she can be? That's the differential we care about. But on the public health level, as I said, there's much discussion about this. Often, unfortunately, a rush to just labeling it racism or even systemic racism. Well, if you label something systemic racism, which probably isn't wrong, but it gets you nowhere. So it's not actionable. It doesn't really lead to a particular solution. But what I wanted to say, and I don't hear many folks making this point, is that there's I would say it's kind of a fixation with, reducing the gap, closing the gap. And on its face, that's not a bad goal. In other words, facing this differential between, let's say, treatment for the same condition. But I guess what I just like people to think more about when they leap to this idea about we have to eliminate, that's a phrase, eliminate disparity, are three things. One is when you compare groups, you have to be much more attentive to the subgroups within that group. So to say Hispanics or Asians it gives you some information, but for these epidemiologic purposes, you really want to separate out the subgroups within the groups because some may be doing very well, probably better than whites. The other is that if you really take the gap closing agenda seriously, you are going to consider increases in the status of both groups to be a failure. If they both increase, but there's still that remaining gap, you'll find there's nothing to celebrate and there's still a problem. And the other is that, you know what? I've sort of blocked on what the third one is. I'm sure it'll come to my mind about why the approach to closing the gap is just a little less straightforward than it is. Okay, here's the third one. That perversely, what might be considered a success is if, and usually these are white black, usually the disparities are white black, that if white people do worse somehow, and that could certainly narrow a gap.
Mhm.
That's no success either. So, and I've seen a few, admittedly a handful of situations where, well, some people were, some analysts were actually considering this a success because yes, the gap lowered, but it's because the white people weren't doing as well. That's no success either. So I think that agenda has to be thought about a little more carefully. But the larger issue, which you alluded to, and echoing Professor Kennedy, which is that yes, there are these differences, but how can we address them in a way that's most productive? Meaning, how can we address it in a way that improves minority health and but not because at the cost of any other group? We can all be healthier.
Mhm. Yes. Now, the way I see it, what we now today known as anti-racism has roots from decades ago, right? So it's basically the assumption that disparities between the races implies that there's some racial discrimination going on. So disparities equal racism. Um, and also the the anti-racist ideas in the field of medicine, I believe that conversation goes back even before George Floyd. I remember in 2016, 2017, there was this conversation around uh, dieting and how Black people have a much higher rate of contracting diabetes than whites, and they say that is um, because foods, fast foods and unhealthy foods are cheaper, and Black people tend not to have the income necessary to buy, say, healthy cuisine. Um, and yeah, I believe there was this one essay in the 1619 project that discusses this also, and Eric Adams, before he becomes mayor of New York, he writes about how because Black people have made soul food to be their cuisine and is very unhealthy. He warns against the sort of caloric intake as well as the large amount of carbohydrates and unhealthy fats that's in that food. So I wonder if you find this I guess explanation to be valid.
Oh, there's in this kind of a discussion, there's almost never one causal element.
Yeah.
Sure, that's part of it. Diet's always part of it, and taking one's medications. I mean, that's probably one of the bigger problems with people of all white, black, Hispanic who have like what are probably the three main chronic illnesses: asthma, diabetes, and high blood pressure. Of course, diet does play a role. There's no question, but adhering to the medications is really can make a huge difference. And that's no fun, admittedly, and especially watching a diet is no fun. But but that's very important, and a lot of time is really spent on how to increase adherence or compliance to regimens. I think there are all kinds of creative ways to do that, but that's really important. And just bringing it back to anti-racism. Um, if you follow the sort of the anti-racism ethos, that of course, gets us to this, the classic oppressor-oppressed dynamic. And if you're a, minority, then you're oppressed. And if you are, then you don't have really, then it takes a lot of the focus off what people can do for themselves, because you're always in the position of having something being done to you. And I have to admit, I can't imagine that even the most kind of anti-woke doctor, if they're in a room alone with a diabetic patient, that they still don't talk to them about, trying to watch their diet and exercise a bit and take this medic. I cannot believe they do not do that. And if they did, it would be really a massive dereliction of duty. But the general philosophy of anti-racism would discourage you from those kinds of interventions, from having expectations of patients. Now, that's not everything. There are all kinds of innovations that some hospitals are doing, where they send nurses out, they have groups for patients that where they talk with others about how they're modifying their diet. I mean, and this is social, a lot of this is social service. Some medical centers have, transportation, or Medicaid actually even pays for vans or an Uber sometime. In DC, I think if you have a certain kind of Medicaid, it'll pay for an Uber to come to the clinic. And people have transportation problems, and a lot of them have wheelchairs or, really a lot of musculoskeletal problems that make it hard for them to get around. So, things we can do like that to make it easier are all valid and should be pursued. But those are the kinds of solutions we should be looking to, not, for example, if I can just recite some of the manifestations of an anti-racist approach, was for a lot of them go back to COVID because it was most dramatic then. But I'm sure you recall that when the vaccines first became available, basically you had to adapt a rationing, mindset, because not everybody could get them at first. So I think everyone agreed that people who were on the front lines, doctors and nurses, had to get them because they had to be healthy enough to take care of other sick people. And then there was then there were lists, and there were the what are those called, essential workers. And but then there was a suggestion, really wasn't a suggestion as much as it would have gone into effect had the CDC adopted it, a suggestion from the Advisory Committee on Immune Practices, which is part of the CDC, that basically, if you were Black, you would get extra points, let's say, to make you a higher priority for vaccination. Well, that's not how we distribute health, and especially in a relative emergency context. I mean, that's not how you triage. You triage. I mean, there are several ways to triage. I mean, there's a big literature on triaging, and we see this a lot with the kidney or the transplantation organ situation. So for kidneys, it's pretty much first come, first serve, because you can stay alive for a number of years on dialysis. But for livers, the sicker you are, the more likely you are to get the transplant. In some cases, it could even be random, just like almost a lottery. I mean, depending on the actual thing that's being rationed. But but the point is, this is not a time for reparations. And I'm not being flip. I mean, that actually is was not even maybe a metaphor, but that was the sense, fully expressed as such, behind the rationale of giving extra points to people simply because they're Black. Now, you could argue, and I think this is legitimate, you might want to base it on communities. This is what the National Academy of Sciences suggested, that it was basically a social index that has to do with rates of poverty and other kinds of disenfranchisement, but independent of race, because those other factors made people medically, clinically more vulnerable. That makes sense, but race in and of itself didn't make sense. Someone else just thought at the time, this didn't get as much notice, but it was in an op-ed in the New York Times by a bioethicist at the University of Pennsylvania, that basically the same logic should apply if we needed to use ventilators. It turned out we didn't. The ventilator route was not as much needed as we thought, but nevertheless. And then the one that really sticks out in my mind is when during the George Floyd marches, there was an epidemiologist at Johns Hopkins, who I really should have her tweet in front of me, but I'm paraphrasing it, I think faithfully, which he basically said, go out and march because racism is a public health issue. And I guess if you connect the dots, and by marching, you will somehow subdue racism. Well, whatever. That to me was just a stunning thing to say, because what public health experts do is they estimate the risks as best they can. They're not perfect. They make mistakes, but they're in good faith. They estimate the risks, and then it's up to the citizens to decide what they want to do with those risks, if they want to expose themselves to those risks or not. We're told the risk. We should not be told by public health experts which risks are and are not worth taking. And needless to say, if the march were for, I don't know, Trump or pro-life, they wouldn't be telling you to get out there. So there's that hypocrisy. But even more than the hypocrisy is that there was a departure from role. And I think that's really important. That's not what a public health expert should be telling you to do. And this bleeding of politics into clinical advice and clinical practice is really what is the core of what's wrong with the anti-racism social. I prefer saying social justice because it's broader, but that's at the core of the encroachment of the social justice mission into health.
Okay. Um, so I'm glad you mentioned COVID because that's the topic of my next query. I believe that in 2020, and this is a fascinating discovery, I discovered that there was an interview with Robert F. Kennedy Jr. recorded that year with Mike Tyson. Um, and um, that makes me think of how his like anti-vaccine rhetoric appeals to uh, Black Americans uh, because of the Tuskegee syphilis experiment. Black Americans have had like very negative view on injections and inoculations and vaccines in general. And I think around that time in 2020, I guess news of the vaccines being developed, was distributed, and I guess that's where the knee-jerk skepticism comes in. Um, I suppose you can briefly discuss what the Tuskegee experiment was and to what extent is that kind of skepticism by Black Americans valid? Are they valid?
I can give you a superficial description. Actually, Richard Schrader at the University of Chicago studied this in great depth. But basically, it was a United States Public Health Services trial of syphilis. They did not give syphilis to people. That's a myth. No one got syphilis. These folks, poor Black men mostly, had syphilis. And the idea was they really, when the experiment started in 1932, I think, there really weren't good treatments for syphilis. But in the meantime, penicillin, which is a good treatment, especially for the early stages, did come about. And it wasn't offered to some of these, or I think it wasn't offered at all to these men. And, and that was the bioethical scandal here. So yes, and one of the ironies of that is that they were mostly recruited actually by a Black nurse into the study, but yes, the shadow of that is long, but I haven't seen, and I mean to look at polls. Have you seen any surveys or polling on how much the Tuskegee experiment does influence attitudes? The reason I ask is because when, again, 2020, when this issue came up, and some Black people thought, I don't want to go first. I don't want to be the guinea pig, but is that I tried to read a lot of comments on articles that talked about this, and they were all over the place. Some people did invoke this as a reason for suspicion, and others said that, basically that it was too convenient and that it really isn't that much of a concern, and that they were skeptical. These are all African Americans. They identified themselves that way, skeptical of people sort of trotting this out as a reason to be skeptical. But then again, I don't know, the education levels of these various people and their background. So I think the safe thing you can say is that it's not homogeneous. Attitudes about Tuskegee in the Black community, or what I mean to say, that probably, I think there's pretty uniform attitudes in the United States that it was a horror, but that how much it influences attitudes now sounds like it's just varied within the Black community. I know that, but one has to wonder as well. I feel this is really politically incorrect, but and this is true with all the concern of racism in medicine, is that I'm not saying there are no problems. I'm certainly not saying that. I see it every day. And as I say, I work in a methadone clinic, and let's just say it's not a gleaming clinic. I mean, these, I actually love it. Love the people who work there. I really like the patients, but when you come to a methadone clinic, it's really kind of end stage treatment for addiction. And I don't mean that you're near death. People are on methadone for years. And we just admitted an 80-year-old guy. So, I mean, you can really be on it. It's an otherwise safe medication. But I mean, the point is that I do wonder how much we feed this anxiety, like by so much discussion of racism in medicine. I mean, as I say, things aren't perfect, but I think doctors really do care about their patients. I think that there are ways to make things so much easier for poor, especially poor working folks. We can have public health clinics that are open at night. If these clinics are, they're staffed by some physicians who may or may not be from the community, but they're almost always staffed by nurses and, other and the secretaries and the other personnel. Those are the people from the neighborhood. And that goes such a long way to making folks feel at ease. Not, there's so much talk about, I'm being a little bit, I guess I'm making a little bit of an exaggeration of this, although I have seen it exaggerated a bit, that now we need more doctors because Black patients should be treated by Black doctors, or only Black doctors can understand Black patients. I'm not saying that there's no connection. I'm not necessarily denying that, although I always think class often trumps race in many of these situations. But the doctor doesn't necessarily. I'm the white doctor in my largely African American, methadone clinic, and if patients, may not feel that comfortable with me, for a lot of reasons. I'm not saying it's race, but then I have 10 Black nurses and counselors to say, oh, she's, she'll help you. She's good. That kind of thing really, really does help. It helps the patients. From the standpoint of the percentage of Black doctors, sure. I mean, it's underrepresentative of the population. It's about 5%, and otherwise it's 12 or 13%. So on principle, it would be nice to reflect the composition of the country, but it doesn't mean that we should. It doesn't mean that folks are getting poorer care, and it certainly doesn't mean, and approaching a third rail issue here, that we have to sometimes lower standards to accomplish that. And that's a big part of the anti-racism effort, is to really triple down on affirmative action. I don't think that medical school is the level at which the point in the pipeline where we should be doing that, because it's patient care. That's what we care about more than anything. And we want the best the best doctors to do that. And so that's a difficult, sensitive problem as you can imagine, but merit has to take priority.
Yes, of course. Yeah, I agree with that. I'm sure this has happened within your lifetime that when the AIDS crisis happened, there was an overwhelming number of Black Americans who believed that AIDS was manufactured by the American government, and Black people were being affected by the AIDS virus intentionally. Um, I think on the surface that is patently false, but the fact that an overwhelming number of Black Americans believe that, and I think it is still mentioned in like certain rap songs that I hear today. It's fascinating. Why do you believe that to be the case?
Well, that was also the case with crack, that the CIA was importing crack. And I think that's a measure, it's a reflection, I think, of the desperation people feel living in these communities that are so devastated. And that largely started in the 40s and 50s as they became deindustrialized, and urban urban planning, that's not the right word. I'm blocking on the name for urban renewal. Yeah, that was it. These were, again, like so many things, well-intended efforts to change transportation pathways. So they would like put, a highway going through maybe a poor community, but a community that was intact and had businesses and had a thriving church, and it just destroyed these places. And so when there's so much misery, I think you look for explanations wherever you think you can find them. And they didn't say aliens brought this in. I mean, it has a logic to it. Um, so that would be my first answer. I'm sure there are more subtle reasons that one could give you, but that's the one that occurs to me, and I'm sure that's the primary one.
Okay. Well,
What do you think? Is that what you think?
um, I suppose it comes from a deep distrust in, well, white society in general and
Yeah,
the government in particular. I think
yeah.
it has been the case, I think, post-civil rights when they believe that the promises made by Dr. King and the civil rights establishments have failed. And
Yes, I agree. Distrust, disillusionment, despair. Yes. So I think it's more of a symptom than anything.
now, you quoted a press release from Mass General Brigham in your article. It noted that, quote, Black pregnant people are more likely to be drug tested and to be reported to child welfare systems than white pregnant people. So it wasn't your focus in this piece, but so the language is very peculiar, right? Pregnant people. I mean, of the two genders I know, one of them can get pregnant, and I think we can guess which one it is. But uh, but anti-racism in medicine also overlaps with this desire to placate the trans people, which is a much smaller community population than Black Americans. So why has this particular population, the trans population, managed to wield such powerful influence?
That is such a great question. I must ask that every week. I wish I could give you an answer other than the fact that when you look at the stories of Michael Bailey at Northwestern and some other, well, Abigail Schreier much more recently, but people who have challenged some of their tenets, the blowback is just intense and vicious. So that does have some impact for sure. But I also think, most people in medicine these days are very left of center. And I think and well-meaning and very, 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 very amenable to the oppressed, the narrative of the marginalized and the oppressed. And I mean, the true narrative that these are folks who you know, are in a often underserved and under-recognized situation. But again, in an effort to compensate for the difficulties they've had, and especially trans people, they have been so discriminated against and so mistreated that that they kind of become almost tolerant in a way that's incontinent. It's just that it's too broad. Their critical faculties honestly get a little diminished sometimes. They're just so eager to make people feel welcome and to compensate for, past mistreatment, that they really don't think as carefully about certain situations as they should. And if I may give you an example, the the American Psychiatric Association publishes a lot of books, and these are not books that are official publications of the APA. So it's not like the APA handbook on something, but they peer review them. I mean, I could apply to write a textbook to be published by the APA on treatment of depression, for example. And it would be peer reviewed by the APA, actually twice, they tell me. So they just put out a book on gender affirming, a textbook on gender affirming care. And it was supposedly vetted twice. And the book is, if you read a textbook, you would expect to hear what's going on in other countries, how other countries are dealing with this issue, because it's a textbook. And you want to know, you want an even-handed account of how this problem is being treated where it exists. Now, that book came out in December. The Hillary Cass report just came out last week, which basically says that the United States is really behind in following the data, or lack of data. That's one of the problems. We don't have enough information on some aspects of hormonal, like puberty blockers and hormone replacement. But this book did not say one word about the UK, where this debate's been going on since at least 2000, I think, publicly. Norway, Sweden, France, Netherlands, didn't say one word about their reservations, and how in some of those countries, in children, I should say, in teens and children, these kinds of interventions are experimental in some of them. That wasn't discussed. Basically, the message of the book is, if a 5-year-old, admittedly that's young, but there have been kids that young, well, let's just say a 10-year-old, 12-year-old says they think that they are a different gender, you just take them at their word, and that's the end of the story. No further deep exploration, no psychiatric care, no effort at what's called differential diagnosis to look at what other problems they may be having, and whether or not their gender dysphoria is a manifestation of those deeper problems and could be helped by attending to those deeper problems. And this is a textbook from the American Psychiatric. So I guess it's a long roundabout way of confirming your observation that this is almost endemic in a lot of American medicine. The American Pediatrics Association is certainly in favor of this kind of very, very expansive approach. Basically, believe the children, which is not to say that this doesn't exist. This phenomenon of gender dysphoria may not exist, and that for some minority of kids, acting early may be the best thing for them. But to not exercise any skepticism or consider the other side of this in a textbook that is going to be authoritative and is going to be used in courtrooms now is evidence, again, of the almost, this uniform endorsement of a clinically, frankly, bankrupt approach. So I guess in a way I'm just describing what you had already said. Why exactly it's infiltrated so deeply, I don't know, other than people are, this is a very aggressive uh, lobby, I would call it, and people are scared, and there is a lot of there's a lot of nervousness in medical schools. A lot of people do, because I speak to colleagues all the time, and I even had my own little cancellation or near cancellation episode. Certain things that if you bring up, I'll just give you one example. I know we're getting to the end of your time, but colleagues of mine were discussing the increasing rate of suicide among young Black boys. And the only explanation in this discussion that was acceptable was that, again, it was racism. They were oppressed. They couldn't consider the fact that teens just often feel very, very, very frightened of gang activity and the pressure to be in that, of the family losses they've had because of gun violence, of the frankly, some of these neighborhoods are, they're risky for the poor folks who live there, and there's a real level of fear. And some of them, unfortunately, some of them grow up without, you know, intact families. That's depressing. Certainly, kids often feel very lost and very much looking for adult love and supervision. And but none of these could be discussed, only one. So the way it's narrowing the discourse, and then it also affects collegiality, because then, you know, people are either working on eggshells or they're saying something that's perhaps a little, in this climate, a little risky, and then people mob them. It's just not a healthy environment. So, I mean, there's so much more to say, and I realize that, time is limited, but maybe you can link to the article in Liberties that I also wrote another article in Liberties on the social justice in medicine. I called it critical race theory, but I wouldn't call it that now. I just call it social justice in medicine. It's a worrisome development, um, in which actually I think there's an effort to really change the identity of physicians to be activists first, and to think of medicine as a vehicle for social justice. The way we do social justice is give patients the best care we can.
Mhm. Yeah. I think so here's a final note to end on in relations to the trans debate. I'm sure you know the academic Deirdre McCloskey. She's very well-known economist, and I think frankly, if you read like much of her academic work, you wouldn't know that she's a trans person. I know she wrote a memoir about her transition,
Right, yeah,
but
crossing.
overall, she doesn't make a big deal about that part of her autobiographical life. And during this time when we are all talking about transgender issue, she seems quite silent on it. So I always thought that maybe activism is not her her thing, but yeah. So tell me why she is not
I
like.
don't really, all I'll tell you is read Alice Dreger's book,
Mhm.
Galileo's Middle Finger, and I think you'll see more of her activist side.
I see.
Yeah.
Okay, that's wonderful. Okay, I think that's a good note to end on. Thank you very much, Dr. Sally Satel, for joining the show.
No, thank you so much.